Hello everyone, my name is Joyce and I am part of Group 16 along with Avni Patel, Jenny Shoskis, Paulina Fan, and Sasha Watson. We performed a critical appraisal of the article titled Cost Effectiveness of Tiotropium versus Omalizumab for Uncontrolled Allergic Asthma in the United States. This table looks at a general overview of the pharmacoeconomic study. We will discuss each aspect in more detail later. The main arms that were being looked at were tiotropium or omalizumab as add-on therapy to the standard combination of an inhaled corticosteroid plus a long-acting beta agonist. The population included patients with uncontrolled asthma, and the comparator was standard therapy, which in this case was an inhaled corticosteroid plus a long-acting beta agonist. The outcomes are shown here, and the economic analysis was a cost-utility analysis since quality-adjusted life years was one of the study's main outcomes. Now we will take a look at the introduction of the study, which includes looking at the appropriateness of the study's title and taking a closer look at the pharmacoeconomic question. The title of the article is Cost Effectiveness of Tiotropium versus Omalizumab for Uncontrolled Allergic Asthma in the United States. The author did a good job at including the country, study type, and disease state. I stated earlier that the economic analysis was a cost-utility analysis since quality-adjusted life years were analyzed. The authors called the study a cost-effectiveness study, and as we learned, a cost-utility analysis can be considered a subgroup of a cost-effectiveness analysis, so the study type stated by the authors is still appropriate. As for the comparators, it is unclear what the comparators are if one is only reading the title of the study. It's not until later, when one reads further into the article, the reader learns that the comparator is actually standard therapy, which in this case is the inhaled corticosteroid plus a long-acting beta agonist. There is also no mention of the setting of the study in the title, whether it's a private hospital, a private health insurance company, government agency, community pharmacy, or others. Moving on to looking at the appropriateness of a pharmacoeconomic question. You can see the pharmacoeconomic question written out on the screen. The pharmacoeconomic question was found at the end of the background section in the article, and as you can see, the authors clearly state the three different treatment arms that were performed, including standard therapy of an inhaled corticosteroid plus long-acting beta agonist, along with add-on therapies of tiotropium or omalizumab.
Next, I'm going to go into a discussion and critique of this article's methods, including the use and implications of the study perspective, the relevance of all the costs of the study, the relevance of all the outcomes, the adjusting and discounting methods, as well as the impact of study assumptions. As for the use and implications of the study's perspective, the study setting is explicitly stated to be that of a U.S. societal perspective, which is what health economists do prefer to see in a cost-utility analysis, because this perspective is so broad and it includes all the costs and outcomes. As for the impact of study assumptions, the authors do state that they assume the same health benefits of tiotropium for both allergic and non-allergic asthma patients, as supported by a post-hoc analysis. However, no such study was found for omalizumab to make the same assumption. It's important that these assumptions were stated explicitly by the authors and not left up to question by the reader. The outcomes of the study include the number of weeks with non-severe exacerbations, the number of weeks with severe exacerbations without hospitalizations, the number of hospitalizations, 10-year costs, QALYs, and ICER. Non-severe and severe exacerbations with or without hospitalizations are both important outcomes to clinicians, and they're used to assess severity of illness and guide treatment decisions, so they are clinically relevant. Also, 10 years is an appropriate duration of time to conduct this study due to the fact that asthma is not an acute condition. Exacerbations and/or hospitalizations can occur at various time points throughout multiple years. There were no secondary, tertiary, or proxy outcomes named. As for the costs, the main analysis includes both direct and indirect medical costs. Although the societal perspective is appropriate for the CUA, the costs are not appropriate, since the societal perspective should include all types of costs, including direct medical, direct non-medical, indirect, and intangible costs.
So in terms of adjusting and discounting, all future costs and the QALYs were calculated over a 10-year period, So discounting was used in this case and with a rate of 3%. There was no reason that 3% was used, but this is often used and generally accepted. For the costs, they were all adjusted to 2013 US dollars using the US Consumer Price Index. Next, we're going to be talking about the results and discussion sections. On the right, you can see the results presented of this study. Our primary focus is on the QALYs and the ICER for the three treatment options. The data shows that add-on therapy with tiotropium was associated with an ICER of $34,478 per QALY, relative to standard therapy over a 10-year horizon. In comparison, add-on therapy with omalizumab had an ICER of $593,643 per QALY relative to tiotropium. The addition of tiotropium would be considered cost-effective compared to these other two alternatives at the conventionally used WTP of $50,000 per QALY. Omalizumab showed the highest effectiveness both in terms of improvements of QALYs and reduction in the number of exacerbations, but this came with substantial incremental costs. In the end, omalizumab was dominated by tiotropium as add-on therapy.
So next we'll be discussing the impact of the results on clinical practice. So, previous studies have compared cost-effectiveness of omalizumab as an add-on therapy compared to standard therapy of just the combination of ICS and LABAs. A comparison, however, has not been done between omalizumab and tiotropium, which have both been recommended as add-on therapies. So the authors believe that in order to help clinicians and providers give better care to patients with uncontrolled asthma, this sort of data is really important for them. Additionally, they also conclude that the data generated in the study can be used to help policymakers make better decisions. These were the implications of the sensitivity analysis results. So sensitivity analysis was performed on different aspects as portrayed in this chart. This includes cost of omalizumab, time horizon, 30-day probability of death from severe asthma exacerbations, utilities, etc. However, the one that has the most impact on the outcomes were the changes in costs of omalizumab. A decreased cost of omalizumab of about 25% decreases the ICER relative to tiotropium from base case value to $436,944 per QALY. On the other hand, an increase of cost of omalizumab by about 25% will increase the ICER relative to tiotropium from base case value to $753,214 per QALY. However, changes in the other variables listed above did not show significant change towards the outcomes. Therefore, they will not be discussed here.
Looking at the study limitations and impact, first of all, the study addressed the limitation that no direct comparison was done of effects of tiotropium against omalizumab. Therefore, the true efficacy between these products is still not well understood. Secondly, the study utilized the assumption that health benefits of tiotropium are equal for both allergic and non-allergic asthma. However, there is data to support this assumption. Next, there's no published transition probabilities for omalizumab across health states, and the study utilized back-calculated data to calculate these probabilities, and therefore this may not accurately represent true transition probabilities. We also found two more additional study limitations. The first being that the study measures the number of weeks with exacerbations rather than total number of exacerbations. Therefore, this may not accurately represent true asthma state and could potentially underestimate QALYs. Finally, we also found the limitation that the study does not capture intangible costs for societal perspective, and this may also lead to underestimating the total cost. Next, we are going to analyze the conclusions of this study. Overall, the authors concluded that although omalizumab had the best health outcomes, add-on therapy with tiotropium was a cost-effective alternative to omalizumab and standard therapy for uncontrolled allergic asthma.
when utilizing a willingness to pay of $50,000 per QALY. However, this conclusion was not included in the actual conclusion section of the report, as it was included within the results section. Within the conclusion section of the report, the authors stated that although asthma outcomes have improved over the past few decades, a minority of patients still remain symptomatic, and further CEAs are essential to assessing emerging treatment options for patients with uncontrolled allergic asthma. Our critique of the author's conclusion is that this conclusion is a more general statement of the benefits and shortcomings of current and emerging treatments options for asthma, and does not actually include a clear statement from the authors about which of the three compared therapies is most cost-effective for treatment of asthma. This is the end of our presentation, and we'd like to thank you for listening. If you have any questions, feel free to post them in the comments section.